Welcome to Mastering and Guideline in Ultrasound and Echo. Hi everyone. Before I start this presentation, I want to mention 2 points. First, there are 4 other lectures that related to this. I strongly recommend go check them out, and I am sure you will love them. This one is public, the other 3 is accessible in the master group. You will not miss anything if you check them out and review them. Second, almost all the material and content of this lecture result of these people works, and in advance I appreciate all of them for their great job. And I strongly recommend for especially resident and doctor, check those articles if you want to go more detail and have all information. Now let's do it. Carotid atherosclerosis is responsible of 20% of cases of acute ischemic stroke, including TIA or mini stroke, around the world. And the first tool and technique for evaluation of the carotid is ultrasound. In ultrasound, we have to evaluate, we use and evaluate carotid by 3 modality: 2D, color Doppler, and spectral Doppler. Let's go first. We start with the 2D finding and evaluation of the carotid ultrasound. As I mentioned before in the other lecture, we use in probe between 7 to 12, depending on the size of the neck and some other characteristic of the neck, and linear probe. But sometimes maybe we have to use a Kelvinier and lower frequency, sometimes 5 or 3 even, depending situation how much penetration has and we have good image or not. And for the Doppler study that is defaulted in the probe and software for carotid ultrasound, used 3 to 5 megahertz. When we evaluate 2D of carotid, we have to focus on attention in 4 characteristics of the carotid and any lesion inside of the carotid. First, echogenicity. Echogenicity in atheroma or plaque in the carotid can be mid-gray isoecho, like the same as the muscular in the neck, mid-gray, or can be a little hyperecho or a little or hypoecho. And for the another characteristic we have to attention is the border and surface of the plaque. Is that smooth and regular or irregular and dentated? Is that any ulceration? We can see any ulceration or not, because ulceration on the plaque is high risk for the embolus, because it can detach and go to the circulation to the brain. For the ulceration, we have to optimize our image in 2D, and if you see any irregularity at the surface of the plaque, always we have to think about ulceration, if there is any ulceration or not. And for that purpose, optimizing image in the highest grade and using magnifier and color, many times we can detect it, but most of the time we need other modality. And in that cases, we use power color, or in some very high suspicious and negative study in those other 2 techniques, we can use contrast study. And in that case for ulceration is any indentation that go in more than 2 millimeter, it is proving we have ulceration. Another one is the size of the atheroma and plaque. Before I go for measurement of the plaque and all other 2 finding, I have to mention that whenever IMT, Intima-media thickness, any time that IMT diameter thickness goes over 1.5 millimeter, we called it plaque. Besides of the any lesion that we see in the carotid, including usually is plaque, we have to be aware of other pathology when we scan carotid. At top of them is dissection of the carotid that it can show as a flap. It can be very sharp and flail, independent of movement of the wall, and if we move around different angle, still will be there. And the final, if we put color, we can see double flue or duct that is typical of the dissection. In any other situation, we will not have those characteristic, and so it will be artifact. So you have to be aware with changing insonation, direction, orientation, short axis, long axis, and final with putting color, we can prove if there is any dissection or not. And very important for this diagnosis that your optimize should be very good, because if too much dark, you can miss it very easy, or if it's too much, you can create artifact and get impression of the dissection. So with all those features, we can detect it. That I'm not going to talk about this topic in this lecture. Another one, whenever you scanning carotid, if you see any structure between those two ICA and ECA, always we have to be aware actually three possibility. First, leaf adenopathy, that it is another story, has a specific characteristic and so on. Another one is carotid body tumor, that is even is not common, but is not, you will not be surprised that maybe you see, especially when you see isoecogenic between these two ICA and ECA branches. Always be aware of that. And another one is sometimes post surgery and repairing with the end artectomy, and they put the stent. We can see a stent as usually is metallic, and linear pattern of the board wall of the stent is very typical and classic. That later we talk about that in detail. Here I forgot to mention, this is a B-flow modality that some vendor, they have it and use it. It is very good for those situations that we want to have more clear blood flow and more detail. B-flow is a very good modality instead of the color, or add-on for the color information. It gives more information and is very helpful. If you have it, try to use it. In 2D, beside of the characteristic of the plaque and lesion, we have to measure the size of the atroma and the grading of stenosis based on the 2D measurement. For that purpose, we go to get a longitudinal view of the plaque and vessel, and then we have two techniques. One of them is traditional, that in that technique we go measure the narrowest diameter of residual duct here that is open. Then we go that the same level almost, we measure outer to outer of the ICA. In that case, with putting any of this formula, using this formula, we can grading stenosis of the ICA or ECA, doesn't matter, but ECA is not clinical relevant. The most important is ICA. Nowadays, we used a NASET trial study that in this technique, we go measure narrowest diameter of the residual duct here, and then we go distal to that, and find the spot that the both walls are parallel to each other. Then we measure outer to inner, outer to outer, sorry. If this spot is B here, for example, imagine this one is B parallel to this one, we measure the same. So the closest distal to the narrowest spot, that both walls are parallel, we go measure that one. Again, but by using this formula, we can determine the severity of the stenosis. But the problem with this, there are some problem. But before that, here I have to mention the measuring the size of the plaque. We have to go length, and the highest thicker spot we measure in the longitudinal, and then we go on the short axis, measure third dimensions. And here you can see we measure under this technique the traditional, we measure narrowest spot and the diameter of the carotid almost at the same level, outer to outer. As you can see here, we have two walls here, two walls. One of them belonging to the jugular vein, external jugular vein, another belonging to the ECA. So the border between them will be your outer spot for measurement. And if we use an asset, we have to come at this level, almost this level, you can see is parallel, this level, or even this level still is parallel. We can measure that one, and actually it's more accurate than we go to distal, because it's become too much narrower compared to here, and we kind of the overestimating percentage of the stenosis. But in both of those situations, there is some problem. As you can see here, if we are going to get longitudinal and approach anterior, and our plaque will be lateral like this. If we approach longitudinal anterior in any of these situations, if we go angle little medial, or lateral, on the right side medial, on the left side lateral, anyway, if we go this plane, we can underestimate or actually miss the stenosis very easy. If we fanny a little the other side, this way, we can cut this ICA at this plane, and so we can show is the very stenotic, close to the occlusion almost. So that is the problem with the this 2D measurement. For this reason, before we go get longitudinal, we have to first make sure in the short axis where is location and shape of the plaque. Then based on that, we approach which plane is better for longitudinal. For example, in this case, anterior approach will be overestimating our stenosis. The only way we have to go approach from this way, that is more lateral or lateral posterior approach on the neck. In that case, we can get more correct longitudinal and measuring the severity of the stenosis. But my opinion is that most accurate 2D measurement for grading of stenosis is short axis measuring with the tracing in the residual volume and all of the vessel. How we do it? We go in the short axis, we survey and scan all the way up and down. In the long axis too, side by side. When you find it, the spot is that narrowest and has smallest residual, and being sure that our sector and plane is perpendicular to that level, then we can trace it the residual area and trace the all of the vessel area, then with using this formula and multiple hundred, we can have almost very accurate percentage of the stenosis. Another evaluation in 2D for carotid ultrasound is measuring Intima-media thickness or IMT. And as we know, the normal size of the Intima-media thickness or IMT is less than 0.9 millimeter, and it has been shown in many studies in patient older than 65. If IMT go over 1.2, most probably patient will have two vessel coronary artery disease, and if it goes over 1.3, the patient has the risk of having three vessel coronary artery sclerotic. And so the measurement for prognosis and evaluation of those, especially people over 50 to 65 years old, is very useful and is recommended we do in all patients. For that purpose, we go longitudinal and then 1.5 to 2 centimeter before the bulb here, 1.5 to 2 centimeter before the bulb, and with focusing, optimizing image, we go measure it posterior wall here, as you can see. And the the technique for measurement, we can use manually or automated. Nowadays, most of the vendor ultrasound machine, they have automated technique. We just use option and then select that area. Machine automatically calculate in different and average and maximum everything. Or we can do manually. For that purpose, we have to use zoom in, and then we measure the interface of the intima with the lumen, means cursor here, one cursor here, and another cursor interface of the adventice and the media. You know that we on the carotid wall or any artery, we have three layers: intima, inner layer, mid one medial layer, and the outer layer is adventice. So the layer from the interface of the intima with the lumen and the interface of the hypoecho or unecho media with the adventice here will be our IMT thickness. But you have to remember, even though we measure posterior wall because it has highest resolution because of the blood here and lack of the near field artifact, but in those cases that you can see anterior wall is thicker, IMT looks thicker, we have to go measure that one too. Color Doppler give a lot of information that include detecting blood flow, quality and quantity of the blood flow, that including direction of the blood and relative velocity and the pattern of the blood flow. Is that high velocity or not? Do we have turbulence or aliasing or not? That help us to detect the spot has a narrowing and stenosis. Let's go see how it helps us. First, as you know, the color Doppler works based on the Doppler principle, meaning if the sound goes or blood flow goes toward the transducer or against the sound beam direction, it creates and register by machine as positive shift. If we go away from transducer or the same direction of the sound beams, it create negative shift or negative Doppler. That it can show by color based on what the color setup has been set up. It show those Doppler shift with the color. Let's see a normal color Doppler on the carotid at bifurcation and those two branches, how it looks like and how we read them. Before I go there, just I have to remind you that a good color Doppler should be set up correctly. That the most important dose setup is color scale, wall filter, and gain. Color scale for the carotid artery, especially CCA, ICA, ECA, should be around 30 to 40, depending on the type of the vendor machine and the size of the neck of the patient. And for vertebral artery should be 20 to 30 centimeter per second, and wall filter around 130 hertz. With this setup, we can optimize color gain. Just after we putting our color box at interest area, we increase color gain until blooming happen, means show the blood beyond the border of the wall. In that case, then slowly we slight decrease color gain until color only filled inside of the artery. Here we have bifurcation and CCA. Let's see the pattern of the blood flow. As you can see, we have a steering box. As you know, a steering box help us the change to the direction of the sound beam, because in the vascular study, most of the time we cannot make it parallel sound beam to the direction of the blood flow. So with using steering box, we can change direction of the sound beam. As you can see here, steer box is on the left side, means all sounds go this way parallel to each other and go oblique to the left side, as you can see here. As you know here, you can see CCA blood flow is this way, away from transducer, negative shift, and based on the color box, negative shift show blue, red. And on this ICA, beginning of the ICA, blood goes this way or toward the transducer or against of the sunbeam, show positive shift. That here is blue. And when it goes at this level, almost become perpendicular, zero Doppler shift black. You can see this border of the black, and then direction change and become red, and so on. Here, there are something that you have to know based on this concept, how you can interpret those findings. For example, at the beginning of the ICA, at the level of the bifurcation, most of the time we can see some not feeling blood at the this level. As you can see here, how we can detect if maybe this is some pathology lesion, anechoic lesion like plaque. Sometimes we have anechoic plaque that doesn't let fill it up, or no, it's because of the AD or the insulation that is perpendicular to that area or vortex flow cause this defect and black area. For that purpose, it's very easy. We just, if you change the steer box, make it straight, or better, make it to the right side, blood sound beam become parallel to this area, and it give the maximum blood flow if there is any blood flow. If it feel it, so we know that is the non-lesion, and those mechanisms happen in this case. The most important finding beyond the direction and feeling of the blood flow in the vessel is aliasing. Aliasing helps us to detect the spot and area that has high velocity, or in other words, aliasing can help where is the stenosis, and based on that we can use pulse wave Doppler or spectral Doppler and detect velocity at that specific spot. Aliasing generally is when the blood velocity goes above half of the PRF. That we called it Nyquist limit. If the velocity go beyond that, it create aliasing. or more simple way, if our velocity go beyond the upper limit of our scale, Correl scale, that correlate with indirectly correlate with PRF, it create aliasing. Aliasing, when the velocity go beyond that level, machine or software cannot detect about that, and it wrap it around and take it as a other side. Here you can see. So in the aliasing, we have a color change from those two extreme. Mean here, for example, bright yellow and green at this level. So it has a combination of the yellow and greenish, not to the dark area close to the zero. So we have a bright color map at that level, and it tells us there is high velocity at that spot, or we called it jet. This aliasing we have to keep in our mind that are dependent, angle dependent, and optimizing of the image. First, look at here. In this case, if we steer box make it the left, that this level, the sound beam at the blood flow almost become perpendicular, and because high velocity at this level and perpendicular, it causes an ambiguity of the color Doppler, so a combination of the dark blue and dark red at this level. Just with changing the steering box, we can get over of this problem. Or aliasing not always related to high velocity. It can be in those other situations that machine can register high velocity. For example, on this Thardus ICA, that curving or any curve and starting a bifurcation, maybe we can see some degree of aliasing and is not related to the stenosis. For example, at this two level, that curving, we can see some degree of aliasing. The most reason for that, at this level, the blood flow almost become parallel to the sound beam, and so the registered Doppler shift is highest one and goes beyond the limit of the color scale, so it creates aliasing at this two spot. Beside of the direction of insonation, color scale setup effect on the aliasing a lot. For example, in this case, you can see at the proximal of the CCA, with setting up the color scale around 14, it creates aliasing while we don't have any stenosis at 2D and in spectral Doppler. Or in this case, it create all with the scale around 4, it create all the vessel turbulence and aliasing that even thought we can see narrowing spot, but it show based on the color, it's represent and pretend that there is turbulence at this level and this level too, but the only is here. Or when we increase too much our color scale, it can eliminate aliasing, and we cannot detect where is the highest velocity at the stenosis. The best things, just based on those setup as mentioned, around 30 to 40 is the best setup for the color scale. In some situation that in the color Doppler with sorry, in a color Doppler, we cannot see any blood flow in the some part or all the part of the carotid with all optimizing, that we are not sure if is that completely occluded or near occluded vessel, because the management of each of them is different. Occluded doesn't need any treatment or surgery. Near occluded, yes, it needs. So for those cases, we can do many options. One of the option is we decrease color scale, and if is any a little blood flow, flow, we can detect it by that. Besides of that, we can use power Doppler, increasing a little gain, and all those angling, all those other technique. It can help us if differentiated between the completely occluded and near occluded stenosis. The most important component of the ultrasound of the carotid is Doppler study, your spectral Doppler. As you know, during cardiac cycle with the systolic, the left ventricle pump the blood toward the aorta, and from the aorta goes through the finally those to carotid artery. With blood flow goes to the carotid, we will see a upstroke deflection of spectral Doppler in carotid, and until the end of the maximum systolic function, it get to the highest point that we call peak systolic velocity. After that, the blood flow slowly decrease and go finally comes to the zero baseline. At that level, because of recoiling property of the vascular aorta and other vascular, blood hit the cusp, aortic cusp, and close the aortic cusp, and spectral of the velocity of blood become almost zero. Sometimes because of bulging of the cusp toward the left ventricle, sometimes a little negative shift maybe we can see at this moment, that is corresponds with closing aortic valve. With closing aortic valve, blood suddenly bounces up again, and so we get a second upstroke, and because of recoiling system and property of the vasculature, the blood push to forward and antegrade. So we will have a diastolic blood flow to positive, and finally get to the point that is equal end diastolic, and with that point we called it end diastolic velocity. And after that, shortly, the cycle repeat again, and so on. So we have two parameter, peak systolic velocity and diastolic velocity. Another parameter that we measure is acceleration time, and it start from starting upstroke to the maximum, the time it take get from the end after end-diastolic with the contraction of the left ventricle, start upstroke, blood flow goes to the peak. That we put it exactly at this level, one of them at the beginning of the stroke and another at the peak, with selection the option of the acceleration time on the machine calculate for us this time. With this measuring these three parameters, we can measure three other parameters that are very important, especially in the kidney and cerebrovascular Doppler, but in the carotid are important too. Before I go to there, I forgot that to this notch that goes close to the zero and suddenly blood bounce up again and go forward, this notch we called it Dicrotic notch or Dicrotic notch, that represent closing aortic valve. Those three parameters are resistance index, that represent how much the vessel we interrogate by Doppler is resistance, and calculate by peak systolic velocity minus end diastolic velocity divided by peak systolic velocity. In the carotid ICA, internal carotid artery, the normal is between 0.55 to 0.7. Partiality index is calculated, represent how much the vessel has elasticity, and create recoiling force and calculate by peak systolic velocity minus end-diastolic velocity divided by mean velocity. Mean velocity has been measured by tracing the Doppler in one cycle from the beginning, tracing to the end. That usually this measurement done by the machine, and finally it gives us the partiality index. Another index is flow acceleration rate that we calculate by dividing peak systolic velocity to acceleration time, and the normal is usually over 5 meters per second. Now let's see what the normal Doppler carotid has feature. Before that, I forgot another parameter or characteristic or feature of the carotid Doppler is spectral window. Spectral window is the below our spectral envelope that is free and black, as you can see. In the normal carotid, we have homogenic or parabolic or more accurate laminar blood flow in carotid and ICA. Means we have, when we put sample volume at the center of the carotid, we have a pure and a homogeneous and even velocity. So in that case, it creates a sharp, narrow envelope that below that one is black and we don't have any Doppler. We called it spectral window, especially below this part and some part of the here at the diastole part. So we called it spectral window. In those situations, we have different level of velocity. For example, if we increase our sample volume from the 1 millimeter to the 5 millimeter, it catch up different velocity. As you know, the normal blood flow in the big vessel like the carotid and ICA is laminar, the type of the parabolic. Means at the center all of them are parallel to each other, but at the center has highest velocity, and with moving to the wall the velocity decrease. So if we increase sample volume, it pick up different velocity that at center is higher and the close to the wall lower, so it become broader. As you can see here, you can see broader. So with this specific pattern, when it's from linear and narrow and thin spectral goes to the a little become thicker, we called it spectral broadening. If it's become full, we call significant spectral broadening. That shortly I'm going to talk about that. Now let's see what the feature of normal carotid Doppler we will expect to see. For carotid Doppler, we have to keep in our mind and set up our parameters. That three parameters are very important. One of them is angle correction, that it should be between 45 to 60 degree. And the most important is that for follow-up of the patient has previous one, the new one study Doppler should be the same angle correction. If the previous study has been done by 45 degree, this second time and next time should be the same with the 45 degree, or vice versa. If it was 60 this time, we have to do the same with 60 degree. The best degree among the centers are different, but any between 45 or 60 will be accurate. For making uniform, is better always do on one of them, 45 or 60 degree, that we don't have too much different variance and baseline. Sample volume or gate should be between 1.5 to 2.5, unless we, in some specific situation, we can decrease it or increase it. That later we talk about that. And wall filter for spectral should be around 100 hertz. I have to mention about the wall filter. Wall filter eliminate low velocity frequency, means is eliminate at the baseline whatever velocity we have. This type of velocity, it eliminates those artifact or wall thumb that we have some kick because of the shaking or kicking of the wall. It creates some Doppler at this level. This wall filter around 175 to 100, it eliminates this bump, a negative bump on the spectral, but we don't need it to eliminate that, my recommendation. So keep it, because it can eliminate here, for example, we don't know, even if wall filter is very high, we don't know what is the end-diastolic velocity. Where is that? And is that negative, biphasic, monophasic? We don't have any idea with this high wall filter. So try to not to increase wall filter over 75 to 100. Another one is for the orientation of cursor and blood flow and the vessel. The general rule is that our angle correction line, this line, angle correction line, should be parallel to the direction of the blood flow, not the direction of the vessel walls. So keep in your mind, especially when we have stenosis or plaque, we have to make sure our angle correction line is parallel to the blood flow. And if with that angle is not parallel, just with rocking or heel and toe, we can make it parallel very easily. The spectral Doppler on the usually in the carotid ICA and ECA and CCA, peak systolic velocity is be around 60 to 100 centimeter per second, and diastolic is less than 40 centimeter per second, and acceleration time is less than 70 milliseconds. And it has clear spectral window. As you can see here, we have clear spectral window at the systolic time and diastolic both. Here we have the pattern of spectral Doppler in CCA, ECA, and ICA. The spectral Doppler ICA is low resistance. As you can see, we have significant blood flow and velocity at the end of the diastole. In ECA is high resistance. The end diastolic velocity close to the zero. And CCA is a combination of both. First of all, the spectral window on the CCA is significant and very clear and obvious. You can see here. And we have some degree of the diastolic blood flow forward, but not the same amount of that ICA has it. So it's between these two, and as you can notice here, we have some degree of spectral broadening in ECA and ICA. One of the main reasons for that is the size of those vessels that compared to the CCA is smaller, and since we don't change the sample volume, so we will expect to see some degree of the spectral broadening because the sample pick up some different velocity at the level of the close to the walls too. So we have different velocity, not uniform and even at the compared to the CCA that we put at the center, and they are very close to each other. Another situation that we have to remember is in those conditions that patient has significant atherosclerosis and plaque, and based on the color Doppler and spectral Doppler, it's very hard to differentiate it. That one is ICA or ECA just based on the 2D and color, uh, and even sometimes with the spectral shape, because as we will explain later in the stenosis, those features change. In those cases that we are not sure, even with all those criteria like the branches in ECA and the approaching orientation location of ICA and ECA and what windows we use find each of them. If in those situations we can use temporal tap for that purpose. Temporal is one of the terminal branches of the ECA that goes toward the face and pass through anterior of the ear. In that case, if we put sample volume at that vessel that we are not sure is ECA or not is ICA, we hitting over the temporal artery, tapping many times. If it was ECA over 99%, it creates a sawtooth pattern on the Doppler, and in that case, we are sure that, almost sure that that vessel that we are interrogating and doing pulse Doppler is ECA. Another condition we have to consider when we evaluate carotid Doppler is heart rhythm. As we know, in the old people, especially over 65, cardiac arrhythmia is not uncommon, and cardiac heart rate and contraction, including ejection fraction, all of them affect on the spectral Doppler, especially on the peak systolic velocity and some kind of the end diastolic velocity too. For example, if the patient has tachycardia, not too much high, around 100 or something like that, in that case, peak systolic increased and end diastolic decreased, and it looks like the presentation as the high resistant vessel. But we know that we have to keep in mind, no, that is because of the cardiac rhythm and contractility of the heart. So when we want to interpret that spectral, we have to keep in our mind the cardiac function and heart rate. As we know, in carotid and other major vessel, the blood flow is parabolic. Parabolic is the type of the laminar blood flow that the center, all the layer of the blood flow at different level of the vessel, they are parallel to each other, but from this center is highest. When we move to the wall, the velocity drop, and at the center, based on our sample volume size, the blood velocity is almost even and equal and homogenic at that level. So our spectral Doppler will be linear almost, depending on the size of the vessel, is thin almost, and during especially systole below the spectral Doppler, we don't register any velocity and will be zero or black. That we called it spectral window. With decreasing the size of the duct or vessel or narrowing and stenosis, this pattern a little change, and this layer of the blood flow with different velocity increased, and they become closer to each other. So when we put sample volume at that center of the narrowing or stenosis, the thickness of the spectral or spectral Doppler and curve become thicker, as you can see here. Become thicker, that to this pattern we call it spectral broadening or widening, and spectral window become smaller and smaller. In those situations that we have severe stenosis, about 90 to 95%, or when we have turbulence blood flow that you can see in poststenotic, this spectral window disappear and become full, that we call it spectral filling. The differences between the turbulence blood flow pattern with the severe stenosis is that in the turbulence pattern, not only spectral window field disappear, we will have some negative Doppler at that level too. So beside of the increasing acceleration time on the post-stenotic, but the most important characteristic is that we will see negative Doppler on our envelope. The goal of the ultrasound in the carotid is not only detecting and characteristic of the determined characteristic of the lesion, atherosclerosis, and plaque, is grading of stenosis, how much severe stenosis is. And based on the NASET trial study, it showed that those patients with stenosis between 70 to 99%, they get benefit from the surgery that is endarterectomy. And even it showed that even patients with over 60%, still they get some benefit from the many other complications of the stenotic, especially stroke. The major and most important technique and more sensitive technique for the grading stenosis is Doppler study. And the most important principle for doing correct spectral Doppler is our angle correction line or cursor be parallel to the luminal blood flow, not the parallel to the wall, parallel to the blood flow. As you can see in this cartoon, even though the wall is horizontal this way, but in the turbulence or Aliasing blood flow in luminal here in that level of the stenosis is this way. So our angle correction line should be completely parallel to the our jet, not the wall. And this can be done with the putting angle correction between 45 to 60, and with heel toe we can make it parallel to the jet. In that case we will have very accurate Doppler from the stenosis. For practical point, we can divide the spectral Doppler in stenosis for carotid to different regions: intrastenosis level or at stenosis, prestenotic or proximal to the stenosis, we called it sometimes upstream, and poststenotic region or downstream level. Now let's see each of those region has what type of the blood flow pattern in Doppler. At the stenosis, we will expect to see high velocity and spectral broadening, high velocity at the systole and at diastole both, and widening of the spectral and decreasing spectral window, and in severe cases the spectral window completely disappeared, that we called it spectral filling. In prestenotic region, depending on the severity of stenosis, the flow pattern will be a little different. If we don't have significant, means is stenosis less than 80%, something like that, with the only maybe we can see a decreasing velocity of the peak velocity, a little decrease, and partiality index increase. It is very obvious. In those cases that we have very severe stenosis close to the occlusion, over 95%, something like that, we will see a specific pattern that we call knocking waveform. In this situation, at the proximal of stenosis, not only the peak velocity decrease, the upstroke become more sharp or more vertical. In another word, acceleration time decrease very sharp, and we have some degree of the spectral broadening, and we will not see too much forward or antegrade blood flow in during diastole. So this is a specific pattern for severe stenotic at the level of the proximal to the stenosis. At the region of the post-stenotic, right after stenosis, we will have turbulence blood flow. Turbulence blood flow, in that situation, we have not only spectral feeling, we will see some negative Doppler too. And beside of that, if you go a little further, we will see a specific pattern that we called it Tardus Parvus. Tardus means delay, and it's represented by more flat acceleration time or upstroke, so increased acceleration time. We call this Tardus. And in the peak of the velocity dropped, and it goes down slowly. So we have to this pattern low velocity, peak velocity, and slow down. We called it Parvus. And so to the combination of these two pattern, Tardus and Parvus, we call this Tardus Parvus pattern, that is post-stenotic spectral Doppler we will see in those stenosis, especially significant stenosis. The most sensitive and accurate and acceptable technique for grading stenosis is the spectral Doppler plus a 2D measurement. And it has been approved by most of the society around the world. In this technique, we use two types of the parameter, primary and secondary or additional parameter. In primary parameters, we evaluate and grading stenosis based on the two parameters, ICA peak systolic velocity and plaque, the estimated stenosis based on the plaque on 2D, as you can see here. In the additional parameter, we use ratio of the ICA to CCA peak systolic velocity, that in this parameter on CCA, we do Doppler, spectral Doppler 1 to 2 centimeter before the bulb of the carotid, and then based on those other finding on the ICA, we calculate the ratio of these two. And another is endostolic velocity of the ICA. The additional parameter are very helpful in those situations that affect and we don't have reliable ICA peak systolic velocity, especially like when we have cardiac arrhythmia or cardiac dysfunction, or we have multiple stenosis at different level. So all of those situations affect peak systolic velocity of the ICA. In those situations, these additional parameters will be very helpful and can grade stenosis. One of the most important part in grading of stenosis is differentiation between near occlusion or subtotal occlusion from the total occlusion. In total occlusion means we don't have any kind of the blood completely blockage. We don't have any blood flow through that area. But near occlusion, that happens when we have a stenosis over 95% usually. In this situation, that is needed for surgery, but the total occlusion, they don't need surgery. The most important is we have to optimize and do our best to detecting even a small blood fluid can pass through that area. For that purpose, changing our setup, including decreasing color scale, steer box, correcting steer box, increasing our frequency, approaching in a shallower window. For example, if you're doing lateral, if it's too much far, we go anterior approach or lateral approach. Whatever that we can increase the sensitivity of the Doppler in color Doppler and spectral Doppler to detect trickle flow, that we can, based on that, we can differentiate these two types from each other. Now let's see some important and common abnormal waveform in Carotid Doppler. The first is a Tardus Parvus waveform or blunted waveform. And in this pulse wave, we have two components. One of them is pulsus tardus. Tardus is Latin word, means delay. Pulsus tardus represents prolongation of acceleration time. It takes longer time. The blood velocity goes to the peak. And pulsus parvus is that the peak velocity not only drop, the downstroke become slower. So we have a low pulsatile index. The peak velocity and end diastolic velocity, they become closer, and so pulsatile index decrease. And this type of waveform characterized by low peak systolic velocity, less than 60 usually, high acceleration time, over 70 milliseconds, flow acceleration rate lower than 5 meter per second, and pulsatile index less than 1.2. Whenever we see and face with this type of the waveform, we have to make sure that we have a significant stenosis proximal to that spot. For example, if we scan distal of the ICA at this level and we get this pattern, 100% we will have a significant stenosis before that spot or upstream of the that level or proximal to that spot, means here any spot from here to close to that spot. This type of the waveform usually we will see after distal to the turbulence blood flow, not at the turbulence, distal the turbulence. That means we have low resistance and almost laminar blood flow, but low resistance and low pulsatility. And if we if we see this one, 100%, we have to go back proximal to that region and find where is the stenosis. And Thud flow. Whenever we have total occlusion in the ICA, before the occlusion, we have a specific pattern that blood goes toward the occluded area and wrap around and go backward. So it give a flow pattern. We called it to and fro or yi-yang. That is at the same time of the systolic time, not the diastole. Some specialists use the to and fro for the when we have biphasic. That is not correct because biphasic happen at different time of the cardiac cycle. So the correct one in those cases is biphasic. In this case, we call it yi-yang or to and fro. And if we do pulse Doppler at this level, we can see the same pattern in the Doppler with very small, sharp positive and small negative spectral that we called it Thud flow. If in these cases we do Doppler proximal to the blockage at the ICA, we can see a dampening of the Doppler that it represents and characterized by low velocity and no antegrade blood flow at the diastole. So is dampening that represent high resistance pattern. If we go do a little further and close to the mid CCA, we see the dampening, and not only dampening, that low velocity and lack of the blood flow antegrade in the diastole. We can see the specific pattern looks like ECA spectral Doppler. So high resistance pattern that we call externalization and dampening of the CCA that we will see in the total ICA occlusion. Some specialists again for this dampening use for the Tardus Parvus that is not correct. Dampening is only at the before stenosis. Post stenosis, especially distal to stenosis, we have Tardus Parvus. In those patients that they have near or total occlusion of the CCA, close to the ICA, bulb or before that. In those cases, the blood can go reverse from the ECA through that area and go to the ICA. In this process, the spectral Doppler of the blood flow in ECA become low resistant, and that is the reason we called it internalization of the ECA. In these cases, we have to make sure that is really ICA or ECA with the temporal tap, and the velocity, the spectral Doppler pattern will be low resistant depending of the if we have any stenosis at ECA or here or not. We can have a high velocity or low velocity. Just in those cases with occluded or close to the occluded in the CCA, always remember and evaluate for this phenomenon. As we know, the vertebral arteries are branches of the subclavian. As you can see here, those they go and finally join to each other at the base of the brain and create basilar artery. In subclavian still syndrome, we have some blockage, significant blockage at the proximal to the branch in the subclavian artery, here or here. Depending on the severity of stenosis, we have different pattern spectral Doppler on vertebral artery. If we have significant stenosis but not occluded, usually we will see a specific pattern. We called it or name it a bunny waveform that represent with the suddenly drop mid-systolic velocity. As you can see here, goes upstream, suddenly drop, and then go again forward with a little high velocity. And it gives a pattern like We called it or name it as a bunny sign. In this situation, when the patient do exercise with the fisting and opening hand for 2 minutes, in that situation, if we have significant stenosis, we will see a reverse or negative blood flow at the mid-systolic, as you can see here, after exercise. And it shows we have stenosis, significant stenosis at that side of the subclavian. If we have completely occlusion or close to the occlusion, we will have fixed reverse blood flow in the same side of the vertebral artery. And the reason for that is that blood goes through the other side and goes from basilar artery, and from basilar artery goes back to the subclavian. Or if it's this side, blood goes from basilar, goes to here and supply the subclavian. Here is the criteria for evaluation of the stent in carotid that I'm not going to talk about this in this lecture. Another lecture I will allocate it specific for the evaluation of those type of patient after surgery, endarterectomy, or with the stent. Here are the chart for some important and different type of the pulse Doppler pattern in artery. You can pause it and study by your. As you may notice, there are many other different type of the flow pattern in the arterial or even venous that I am going to talk about all others in different and related topic. Here we have those indication for carotid ultrasound. That's a lot, and I leave for you study if you want it. We are done. Up to the next time. Have a wonderful time.